Okay, and so everyone realizes I'm going to go ahead and mute the microphones now so we don't end up with any background noise for the presentation. And then at the conclusion, when we open up for questions or comments, I'll go ahead and unmute everyone's microphones, all right?
Okay.
Okay, let's go ahead and get started. First of all, welcome. Glad that you could take some time of your evening tonight to learn a little bit about coronary artery disease, heart disease, specifically the blockages that lead to heart attacks, and new technologies that can actually help us to discover these blockages before the presentation of symptoms, before the patient has the first heart attack, and really allows us for the first time to prevent those heart attacks from ever occurring. So very unique opportunity.
Yes.
So a little bit about my background. I'm Dr. Jeff Fine. I'm a cardiovascular physiologist by training, went to the medical school at USC. I also have a PhD in public health through the USC School of Public Health. Was with a large cardiology practice in Columbia, South Carolina for about 10 years, where I worked as a preventive cardiologist, working on early detection and imaging of the heart, exactly what we're going to be talking about tonight, and actually developed the National Heart Health Program, which now I put in all around the world, hospitals and practices around the world, and train doctors on the early detection of heart disease. Specifically, what we're going to talk about tonight is a test called the coronary calcium score. And you might have heard of this by other terms, like a heart scan or a coronary scan. There are several terms for it, but the coronary calcium score is a very, very simple and probably the most patient-friendly test I've ever been a part of. It really is, quite honestly, about a 5-minute test for the patient. It's done in the CAT scan machine that's been around since 1971. Wide open machine, no needles, no contrast, no patient prep, no patient recovery. Very, very simple. You lie down on the scanner bed as the image shows. You slid into the scanner literally for the patient. It's one breath hold. The scanner acquires the images of your heart from outside of the body, and you're up, you're out, and in 15 minutes you can be in and out of the hospital. And for the first time, for doctors, we can actually look at your heart, and specifically the arteries of your heart that become blocked leading to heart attacks, from outside of the body, and tell you definitively if you have heart disease or not leading to a heart attack. And of course, this technology allows us for the first time to look at people who only have risk factors, who are in their 40s, 50s, 60s, 70s, who have risk factors for heart disease, but haven't developed the disease or presented with the disease itself. And for us, that's a game-changing opportunity and really presents an opportunity to prevent patients from ever having a heart attack in the first place. So very patient-friendly test that's at most hospitals all around the world. The unfortunate reality, and really the reason for the value of this test, is that in 2016, 50% of Americans discover they have heart disease by having a heart attack or sudden cardiac death. Those are the initial presenting symptoms for almost half of us. And, that really is completely unnecessary. Again, now with this new technology, and I didn't share with you before, but the cost of the test is generally around $99. So a very inexpensive test that can prevent this 50% from ever having the first heart attack or dying. Again, a game changer clinically and from a life-saving perspective for patients. So the overall goal of calcium scoring as a test is to really be built into the prevention mindset. Really, as patients, I love to give this presentation to you, realizing patients are becoming more proactive and more taking better charge of their health, working with their doctors and making suggestions that their doctor might not be aware of. And calcium scoring is one of those tests where this really fits that opportunity. Many doctors, particularly primary care doctors, aren't aware that this test exists. They aren't aware of the value of the test, of the societal recommendations, of the guidelines for this test. And you as a proactive patient, after hearing this, I hope if you have risk factors for heart disease, which we'll talk about, I hope that you'll take charge and mention this test to your doctor or call your local hospital and sign up for the scan. We don't need to go over all the statistics of heart disease. I'm sure everyone on the webinar is aware that obviously heart disease is the #1 killer of Americans every year, year after year for decades. Interestingly, and I think it's very important to mention, is that coronary artery disease is the #1 killer of females in America, more than the next 7 causes of death combined. So including certainly breast cancer in that category. So while the breast cancer awareness folks do a tremendous job for their cause and raising awareness and the importance of screening for breast cancer, this is a screening test for heart disease, which really would save a significantly larger number of lives if women were aware of this test and utilize this test to their advantage. So as I mentioned, this is a very non-invasive test, around a $99 test available at most hospitals. Again, just a matter of being aware of the test and the benefits of it, and then making it happen for yourself as a proactive patient. Let me tell you what your doctors are currently doing and what they're relying upon in their basis for your risk of having a heart attack or dying from coronary artery disease. The premier tool in America that's been in place for about the last 50 years or more is called the Framingham Risk Index. And what the Framingham Risk Model does is combines a patient's age with their risk factors for heart disease, such as high blood pressure or high cholesterol or being overweight, smoking, etc., and then places that patient in one of 4 risk categories, from very low risk to very high risk of having a heart attack or dying from coronary disease. Unfortunately, the Framingham Risk Index is very good at identifying patients at very low risk for a heart-related event and at very high risk. But unfortunately, it has weaknesses at identifying patients who fall into what we call intermediate risk, that middle range. Those patients are often misdiagnosed by this predictive model alone. To make matters worse, about 2/3 of the American adult population falls into intermediate risk. So there's a very large population of patients, as we'll see coming up on a future slide, that are underserved or even misinformed by Framingham alone. And that's the population that we really want to consider and bring themselves for coronary calcium scoring. That's what all the guidelines suggest, is the intermediate risk patient population. I always like to address the issue of radiation, because anything with a CT scanner these days, appropriately so, should be evaluated for patient safety and radiation exposure. This is a very, very low radiation exposure test. The measurement of radiation is a term called millisieverts. It's 1 millisievert of radiation. To make a comparison, that's almost the exact same radiation involved with a mammography test, and less radiation than you would pick up in the air on a flight across the United States. So very low dose, very patient-safe, patient-friendly test. The basic premise of calcium scoring and the early detection of heart disease is that if tests for subclinical disease, meaning disease identified before a patient develops symptoms, had been available at the beginning of the prevention era, they'd be the gold standard rather than risk factors. And the unique opportunity here is, as patients and as doctors, we can now move beyond managing patients based on their risk factors alone and hoping that it's effective and hoping that they won't develop that first event. In this case, we can actually look in 5 minutes or less for less than $100 directly at your coronary arteries and tell you if you actually have the disease or not. and then manage you appropriately based on the level of disease or the absence thereof, which really changes everything from a medical management standpoint. Some other things your doctors are doing. Stress testing. We've probably all heard about stress testing. Stress test is a very good test, don't get me wrong, but it's maybe not the best test to determine if a patient is at risk of having a heart attack. And Tim Russert's story I include here for obvious reasons. Tim Russert, if you recall, passed away about 6 years ago now from a sudden heart attack preparing for his evening news presentation as a national news anchor. He was incidentally within a couple of months of having a normal executive physical, including a workup from a cardiologist. Because of his position on the national news, he had a cardiologist give him a stress test. And he was given a clean bill of health from his cardiologist. And of course, that wasn't accurate because within a month or two, he had a massive heart attack and died preparing for the news. This is not uncommon. A University of Michigan study showed that almost 6 out of 10 heart attack patients were within 1 year of having a normal stress test. So again, just because you've had a stress test and that result was deemed normal does not necessarily guarantee you're not at risk of a heart attack. The other thing I want to talk about is cholesterol. And cholesterol, keeping LDL cholesterol low is very important. And we certainly want to keep that level as low as possible. I'm not downplaying the value of monitoring your cholesterol. However, again, a person's cholesterol level may not in and of itself be the best indicator of risk of having a heart attack or dying from heart disease. This is a very large clinical study that you're seeing, over 136,000 patients, all in the hospital with coronary artery disease, yet almost 8 out of 10 had normal cholesterol levels. So again, this is a large patient population that had normal cholesterol, would have been considered to be at low risk, yet actually had coronary artery disease. So we really need, if you're intermediate risk, to get the calcium score to determine if you truly have the disease or not. So clearly what we're doing is not enough. If 50% of us find out we have this disease by having a heart attack or sudden cardiac death, we have a very unique opportunity to change the way we manage patients, to change the way we identify this disease and make a difference, get out in front of the first heart attack, and again, prevent it from ever occurring. Let's take a look at a quick case study just to kind of assess what I call the vulnerable patient. And a vulnerable patient is quite simply someone that's walking around under a doctor's care, believing that they're being managed based on their risk factors. They have no signs or symptoms that they have heart disease, yet they may have severe blockages. And these are very common. And this case study will illustrate that nicely. 2 well-known individuals, both were overweight, inactive, smokers. One completely changed his ways, started exercising, became exceptionally physically fit, lost his weight, and became very healthy. The other remained inactive and obese. Both of these individuals had a strong family history for heart disease. So the question is, who would we predict would be at greater risk for the development of heart disease? And on this slide, we see on the left, Jim Fixx, who anyone old enough to remember back in the 1970s was the physical fitness poster child for the President's Council on Health. He became a marathon runner. He was an exceptional physical condition, and yet died quite suddenly at age 53 of a heart attack while running. It interestingly was intermediate risk at the time of his death. And then we have Winston Churchill by comparison on the right, who broke every rule of healthcare or preventive health ever written, and yet led a relatively healthy life till the age of 91. So it just goes to show us that we really can't take a look in the mirror and guess or look at someone walking through our local mall and determine who may be at accelerated risk of heart disease. That's what this test does very well. Had we had the ability to place both of these gentlemen in the scanner and look at their heart disease itself, we would quite quickly have found out that Jim Fixx was the one with severe disease and Churchill was disease-free. So let's take a look real quick. I mentioned earlier that there are guidelines in place, and these are the medical guidelines that determine and dictate who should be sent for a coronary calcium score test. The first one is from the American College of Cardiology and American Heart Association. Their gold stamp of approval endorsement of this test for intermediate risk patients. And their statement is quite simply that coronary calcium scoring is the most useful test to improve risk prediction for intermediate risk patients. It's also tied to outcomes like heart attacks and death over time, and it adds predictive clinical value for your doctors once having this test. So again, that's the gold standard, the endorsement from the American Heart Association and American College of Cardiology saying if you're intermediate risk, you should have this test. The second scientific pillar I want to talk about very briefly is the Society for Heart Attack Prevention and Eradication. This is the SHAPE Society. We actually wrote the guidelines for calcium scoring and the detection of early heart disease and published these, and they're now the guidelines across America and around the world. And quite simply, the patient population that should have the test is males without known heart disease, 45 and older, females without known heart disease, 55 and older, or younger adults that have 2 or more risk factors for heart disease, placing them again at intermediate risk. These are the patients that should be calling their hospital or calling their doctor and signing up to have this test. Just to kind of let you know about the outcomes of coronary calcium scoring, a 0 test is a negative test. It means you have clean coronary arteries, no disease. For these patients, you're retested once every 5 years. This is a great outcome, but keep doing what you're doing, come back in 5 years and be retested. So if and when it does develop, we can catch it early. Positive tests range from a score of 1 into the 1000s. Very early stage disease are 1 through 99 scores. This is where we can stop the disease from progressing and the patient will never have any clinical problems, any signs or symptoms of heart disease. 100 to 399 is kind of the moderately high positive category where your doctor will work with you aggressively to stop the blockages from getting worse. And then the 400 or above score is where you're on to see a cardiologist. These are patients that have likely occlusive or severe coronary disease and represent potentially lives saved. So again, those are the scoring outcomes that you could potentially see having this test. Now the good news is about 40% of the tests are 0 scores and another 30% are early stage, that 1 through 99 category. Only 15% of patients have scores 400 or above. But for those patients, again, it can be life-saving. It is very important. Let's just take a look real quick at 2 quick studies just because they illustrate strong points about calcium scoring that you need to understand as a proactive patient. This first paper is from the New England Journal of Medicine a few years back and looked at calcium score over time, and as calcium scores increased in patients, what was shown was so did major coronary events, heart attacks, death, bypass surgery, etc. The take-home point of this slide, though, is the 0 scores that you can see along the baseline, the orange graphic, the 0 scores. A patient that has a 0 coronary calcium score has a less than 0.5% chance of having a heart attack for the next 5 years, probably about as close to a guarantee as you're ever going to get in medicine. So it's that strong, what we call a negative predictive value from calcium scoring that really allows a patient to realize what you're doing is working, keep doing it. The next study I want to show you really illustrates, going back to when I was talking about the Framingham risk scores, the inaccuracies that can occur in your primary care doctor's office when relying on risk factors alone. And this particular study looked at over 3,500 people. All were intermediate risk, so the population we're talking about. All were given a calcium score to determine how many of these patients labeled as intermediate risk in primary care would really be high risk if we could look at their coronary arteries. And after having their calcium scores, this particular study revealed that 61% of patients that were deemed intermediate risk really were high risk once we could look at their coronary arteries. Now, conversely, 25% of the patients were able to be downgraded into low risk based on having 0 scores. So in total, 86% of the intermediate risk patients out there in the primary care offices were being mislabeled, misclassified, and mismanaged because of relying on risk factors alone versus the calcium score. So you can see the huge potential opportunity here. Let's kind of wrap up with a case study of a very typical patient for calcium scoring, an intermediate risk patient. This is a 47-year-old female in to see her primary care doctor with concerns about her strong family history of heart disease. Her clinical background is she has slightly elevated cholesterol. Both parents had heart disease, as I mentioned, and her physical is normal, and she, again, is without symptoms or signs of heart disease at this time. So relying on Framingham alone, which is what's occurring in 95% of physicians' offices across America, her risk of having a heart attack or dying from heart disease is extremely low, less than 1 in 100 chance. So the appropriate response based on that data would be to provide reassurance and send her out the door. This physician had access, though, to a calcium score machine, sent her to the CT lab for a calcium score, and her score came back as a 106. If you recall, that places her in that moderately high category. When adjusted for her young age of age 47, it elevates her into the 90th risk percentile. For this score, we wouldn't expect to see a score of 106 in someone so young. Of course, her medical management changed dramatically from sending her out the door, reassuring her that she's healthy and fine, to an aggressive medical management strategy to try to stop the progression of plaque. And you can see on this next slide, you can actually see the images of her heart and her arteries. You can see they're in the circles there, and all those white nodules that you're seeing in those circles are all plaques. Those are all blockages in her coronary arteries that lead to heart attacks. Now, the key to this study, beyond showing the disease and the very typical nature of risk factors, is, if you remember, by Framingham alone, she would have been sent out the door believing her risk of either death or having a heart attack was less than 1 in 100. Now that we can see her coronary arteries via the calcium score test, we actually can see that her risk of heart attack or death are greater than 1 in 5. So a significant change in risk for this young lady. And of course, her medical treatment and medical management are changed accordingly. And the goal now is to stop the progression of plaque and prevent a heart attack from ever occurring. So again, to reiterate, who needs this test? Males without known heart disease, 45 and older. Females without known heart disease, 55 and older. Younger adults having 2 or more risk factors that hit that intermediate risk population. Again, these are asymptomatic people believing they're completely healthy. These are the patients that need to have this test and will benefit. I've shared a little bit from the National Heart Health Program, which I'm the executive director. You can see this is almost our first 100,000 patients. As I shared, almost 40% of the patients had no disease, 59% had some level of disease. The good news is the majority of them had early stage disease, which can be easily controlled and stopped from getting worse. And only 13% had scores of 400 or greater, where they're off to see the cardiologist. But for those 13%, this is a significant finding and life-saving. Very significantly, our scores that go over 1,000. These are patients that went on for stent or bypass surgery as a result of this test, even though they were completely absent of any symptoms. And our number needed to diagnose or identify a patient with a score over 1,000 was 1 out of every 29 patients. So those are true lives saved. I'll go ahead and unmute everyone at this time so that we can ask any questions or comments that you may have at this point. Okay. And I'll go ahead and open it up for questions, please.
Hello?
Hello. Go right ahead.
Excuse me?
Oh, go right ahead, sir.
So it has saved lives, this calcium assessment?
Oh, absolutely. Just in our National Heart Health Program alone, we saved over 2,800 lives. That again, these are people that are walking around with only having risk factors, high cholesterol, being overweight, smoking, etc. They have no signs or symptoms. They have no knowledge that they have heart disease in any way, shape, or form, yet they had major blockages that were going to lead to life-saving or life-ending heart attacks. And this is a unique opportunity that this test presents. It saves thousands of lives.
Yes, I guess, yeah, I have a question.
Sure.
This is something new to me, completely. Coronary calcium score is and it's so non-invasive and so easy to do. It sounds like a lot of, is it widely used now in the United States?
You know, it really is, and it's growing tremendously. Like any new test, it takes years for the research to be completed, and then the major societies like the American Heart Association and American College of Cardiology to get on board and endorse it. All of that has now occurred. So now we're seeing rapid adoption of this test. Like I said, almost every hospital, unless it's a very small hospital, almost every hospital in America has the capacity to do these tests. Unfortunately, very few of them are doing a good job of educating the doctors and the patients in a given region about this test. And that's where the gap exists today. And that's why I'm so happy to be here, reaching out and educating patients on this test.
Yeah. I imagine if a patient starts bothering the doctor, hey, I saw this test, coronary calcium score, how come I don't get one?
Absolutely. And, you know, and that's the era we're entering into. I mean, certainly we've all seen commercials on TV from pharmaceutical companies, you know, saying, hey, if you have this, that, or the other, please talk to your doctor about you know, this new medication that might be right for you. That's kind of what we're doing here with calcium scoring, is raising awareness at the patient level that this test probably exists in your own backyard and could save your life. I always told patients it was the price of a nice dinner for two for a test that may save your life. You know, it really, in my opinion, is an absolute no-brainer to have this test.
What is it about calcium, just in a very simple way? Can you explain what the calcium does and why that's important?
Yeah, absolutely. And that's a great question. I'm glad that was brought up. This is not the calcium like in the milk that we drink or the food that we eat, and certainly not our supplements that our doctors have us taking for bone issues. So please don't stop taking your calcium supplements as a result of this, okay? It's totally different. The calcified plaque, and what happens is in the arteries of the heart, plaque starts as cholesterol and then eventually becomes hardened. And that's when it becomes calcified. And that's what the CT scanner can actually pick up in the images, is the calcified plaque. So it is coronary calcium, but again, it's not the other calcium. So it's just the most stable and most advanced stage of coronary blockages is what we're actually seeing. But it is disease itself, and it's the blockages itself. So tremendously important that we detect this.
You may have mentioned it, but do all patients with, like say, 2 or 3 risk factors have calcified cholesterol in their heart?
No, not at all. In fact, only about 6 out of 10 have some level of heart disease. About 4 out of 10 will have no plaque whatsoever. And that's great news for them, and then they get retested every 5 years.
Okay.
But again, for that 6 out of 10, it's very important that we find this disease early and have the opportunity to stop the blockages then from getting worse. And that's the opportunity that this test affords us. Again, if we can find this disease early when there's no disruption, no blockage of blood flow to the heart, and if we can then manage that patient and stop the blockage from getting worse, you'll never have the heart attack. And that's the opportunity this test gives us for the very first time.
You may have mentioned it, but is there a direct correlation between amount of calcified cholesterol and risk? Is there a direct relation? Like the worse the calcified, the more chance you're going to have a heart attack.
Absolutely, absolutely. In the presentation, that New England Journal study showed that, and there's been hundreds. In fact, I've published a study myself on this topic that shows exactly that. That the higher the level of coronary calcification, the more likely the patient is that they're going to have a heart attack or have sudden cardiac death. So yeah, that's well established and yet correlates. Now we can never go from saying a patient has a score of 200 calcium score and that means it's a 30% blockage. We can't quite get that detailed, but when a patient has a score of 400 or greater, as I said, and they go on to see the cardiologist, at that point they'll have a more definitive test that will look in more detail and be able to tell us exactly what the percentage of blockage is, and then from there we know what to do next. So
I'm sorry to ask so many questions, but is this ever used in the emergency room?
You know, that's a great question. That's a great question, and actually that's kind of a growing trend right now, is starting to use this in the emergency room. In fact, I just published a paper with 2 hospitals out in the Phoenix area in Arizona that they started looking at patients who came in that they knew probably weren't having a real heart attack. They were having chest pain, but they had a normal EKG and they didn't have any other signs of heart disease, and they gave them a calcium score to determine if they had a 0 score, they sent them home. And after doing thousands of these over a couple of years, they actually had no patients that returned to the hospital after being discharged who were really having a heart attack. So the test is very accurate at ruling out a heart attack. And I think that we're going to start seeing this used more and more in the emergency department setting. Absolutely.
Does insurance pay for it? Does it readily pay for it, or do they fight you?
Right now, this is a retail service for everyone except for the state of Texas. And again, it's priced at around $99. So you're paying out of pocket for that. Now, you can use a health savings account to make that payment. However, I know that right now the United States Preventive Task Force is also evaluating calcium scoring to mandate that the payers now cover calcium scoring so that there's no copay and no deductible for the patient, just like mammography. And if you fit the criteria, if you're intermediate risk, you'd be able to get that test at no cost to you. So we're hopeful for a positive result in 2017. So we'll wait and see on that. But for right now, it's priced reasonably enough. Again, I always talk to patients about, the cost of a copay for just a trip to the emergency department versus having this test for $99 and ruling out disease. It just makes financial sense as well as preventive health sense to go ahead and have the test. It's cost effective.
Thank you.
So
I was told, because I'm on the statins, that I do not qualify for the calcium test. Is that correct?
No, that's not true at all. No, patients that have high cholesterol and are on statin therapy to monitor that cholesterol are a very large percentage of patients that have coronary calcium scoring. So someone was misinformed, which is very typical. And again, why I've dedicated my career now to training doctors, training hospitals, and training patients about this test. Nope, if you're on a statin, you are probably most likely indicated to have this test.
Because I also have the pacemaker defibrillator.
Sure, and that's fine, because that's an electrical issue, not a plumbing issue, if you will. And so it really doesn't deal with blockages. You would still be strongly indicated to have a calcium score. So I would call them back and question them on that, because they're mistaken.
Okay, thank you.
Oh, absolutely. I'm glad. And that just shows the opportunity here and the misinformation that sometimes is out there. So, well, I really want to take my last minute here just to thank all of you for showing up. And I hope that if you learned something from today's presentation, first and foremost, you'll either call your doctor or call your local hospital and find out about getting a calcium score test, which may save your life. And then secondly, if you got something out of this presentation, please pass along the information to friends, family, coworkers, etc. We're doing this presentation every Monday night at 8:30. This is a no-cost opportunity for others like yourself to come on and learn about new technologies that might save your lives. So please, if you thought there was value, please reach out and share this with 2 or 3 people, and let's work together to save some lives. So I appreciate it, and I look forward to seeing you hopefully next week. I do an introduction to your heart function, and risk factors for heart disease next week at 8:30. If anyone has time, I'd love for you to come join me.